Good morning, everyone, and thank you for coming for our imaging course. We've called it Imaging Clairvoyance, which means probably something to do, that's what ma'am asked, something to do with astrology, predicting what happens by looking at biomarkers, predicting results. So we're going to cover a few topics like epiretinal membranes, macular holes, dry and wet AMD, retinal dystrophies, and diabetic macular edema. And we have a wonderful expert panel and co-instructors with me, Dr. George from the Aravind Eye Systems, Dr. Muna Bende ma'am from Shankar Nethralaya, Dr. Parveen Sen from Shankar Nethralaya, Dr. Sunil from Davangere, and Dr. Rajini Botu from Bangalore. So we're going to start off with Dr. Sunil, who is established vestibular surgeon in Karnataka, the scientific committee chairman of the Karnataka Ophthalmic Society, and very keen into scientific work. Dr. Sunil will be talking to us about predicting outcomes in epiretinal membranes.
Thank you, Ani, for the kind introduction. So today I'll be speaking to you regarding the ERM and how to predict the visual outcomes in ERM, epiretinal membrane. Even with the good surgery, 10 to 20% of the ERMs tends to have a unchanged or the worse vision. So one need to look into what are the predictive factors which causes this the unchanged or a worsened visual acuity. Certain clinical history will give a clue. So the first is look at the age of the patient. The clinical studies have told that younger patients does better. The patients who are aged less than 75 years, 42% of the patients tends to achieve a vision of 20/20 or 20/20. Pseudophakic patients tends to do better. Baseline visual acuity, definitely yes. Somebody who has got a low baseline visual acuity is a poor prognostic factor. Duration of epiretinal membrane, less than 1 year of duration membranes tends to do better than the longer duration membranes. And of course the metamorphopsia score, you can score it, which tends to correlate with the post-op visual acuity. What are the OCT changes which helps us to predict the outcome in epiretinal membrane? The spectral domain OCT studies have shown that the ERM brings about the not only inner retinal changes, the outer retinal changes also. The ganglion cell thickness is one thing which can predict the outcome in epiretinal membrane. So thinning of GCC is expected after the ERM peeling. A greater GCC reduction correlates with the worse post-operative visual acuity. Of course, the thickness of the fovea is a prognostic value. The post-op decrease in central foveal thickness correlates with the best improvement in visual acuity and reduction of metamorphopsia. A higher central foveal thickness to ganglion cell complex ratio post-operatively indicates the improved visual acuity. Cystoid macular edema, definitely a poor prognostic factor. Sometimes tends to involve all the retinal layers associated with sometimes with the GCC thinning, causes disruption of the outer retinal layers also. But the separation of the ERM from the ILM in patients with CME prevents the post-operative CME, and it's a good prognostic factor. One need to differentiate between a microcystoid macular edema from a cystoid macular edema, because sometimes the microcystoid macular edema tends to occur post-surgically. It basically results of the damage to the Muller cells and the change in the osmotic gradient. The one key factor is there will be absence of leakage in cystoid macular edema when compared to the cystoid macular edema. So MME does not seem to have an impact on the visual recovery, unlike cystoid macular edema. Now coming on to the outer nuclear layer, it is the most distorted layer, but the thickness is, there is no correlation between the ONL thickness and the best corrected visual acuity. The studies have proven that also. Coming on to the inner nuclear layer basically correlates with the tangential retinal displacement, and thickness closely correlates with the visual acuity as well as metamorphopsia. So foveal, parafoveal and perifoveal INL thickness is a good marker for the post-operative visual acuity. Sometimes one tend to see an internuclear layer microcysts. They are also poor prognostic factors for the visual outcome. Macular contour, definitely one should look into the pre-operative macular contour. There are 3 types of contour one can see, either dome, flat or depressed. The mean visual acuity gain was better in the dome-shaped macular contour when compared to the flat or a depressed contour type of a macula. Of course, one should look into the foveal pit contour recovery in the early post-operative period. So some patients will have a good pit recovery, one will have a poor pit recovery. Basically, one should look at how far the level of the INL is notched, which gives a clue whether there is a complete recovery or a partial recovery of the foveal pit counter. So earlier pit counter recovery is a useful visual prognostic factor after ERM surgery, which predicts the outcome. And as I told, the separated space between the ERM and the ILM, which is a very good prognostic factor and helps in the easy peeling also. The one important indices which indicates the retinal damage, especially inner retinal damage, is the what we call IRII, that is the Inner Retinal Irregularity Index. So how to measure that? It is basically the length of the inner plexiform layer divided by the length of the RP layer. So you have to look at the two layers and it gives the inner irregularity index. And it can be used as a new surrogate marker for the inner retinal damage, and it is a very predictive prognostic marker for visual acuity as well as for the metamorphopsia post-surgically. You can see post-operatively how there is an improvement on the right side. You can see the values. There is an improvement in the inner irregularity index post-surgically over a period of, but it may take some time, but over a period of 3 to 6 months, one tends to have a good recovery after ERM peeling. The another important entity which has been described is the ectopic inner foveal layer. Basically, is nothing but a combination of interretinal gliosis and physical traction which leads to the ectopic inner foveal layers. So basically, this EIFL leads to the loss of visual acuity. So it is a prognostic factor. So one need to look into the thickness of the inner foveal, ectopic inner foveal layer. How to measure it? You have to measure it from the upper limit of the ONL to the ILM at the foveal center. On an OCT, the lower image, it shows seen as an hypo or hyperreflective band extending from ILN and IPL across the foveal region centered on the fovea. So EIFL is associated with a poor pre-op visual acuity as well as poorer gain post-operatively. Gaviotio has classified the OCT-based classifications. It helps in assessing the prognosis. Stage 1 ERMs are the ERM with the least morphological distortion. Stage 2, there will be retinal distortion, loss of foveal depression, and stretching of the ONL in the stage 2. The more advanced epiretinal membrane, stage 3 and stage 4, are associated with EIFL. But the thing is, in stage 3, you will have clearly identified inner retinal layers, but stage 4, there will be anatomical disruption and disruption of the inner layers, so it is difficult to identify the layers. So stage 2 tends to do better. Stage 3 and stage 4 were less likely to have an improvement. So the presence of ectopic inner foveal layer is more important than the thickness of the ectopic inner foveal layers. So one need to look into this layer, and it's an easy, fast, reproducible method to evaluate the visual prognosis. Then one need to look at the outer retinal layers, especially the ELM, the interdigitation zone, and ectopic, this ellipsoid zone. There is an entity which has been described, something known as outer retinal integrity score. Basically, they look at the outer three layers, ELM, the ellipsoid zone, and interdigitation zone, and you can grade them from 0, 1 to 2 based on the distortion or the discontinuity and how easily the layers are visible. The upper part shows the severely disrupted, the score is 0. The lower part, the less disruption, the score tends to be better. So one need to look at this score. So this score also correlates with the potential visual acuity one can have. The another entity which has been described is what is known as photoreceptor deformation index. Basically, we tend to look at A, B, C. A is nothing but the outer nuclear layer thickness. And from the 500 micron from the center of the fovea, we tend to measure the ONL and OPL. And by using the formula 2A by B plus C, one can detect the photoreceptor deformation index. So this also significantly correlates with the best corrected visual acuity. Another entity which has been described as a A zone on an unfast OCT, which is a homogeneous plaque, black plaque, what is seen. These are the radiating stretch lines. This A zone also correlates with the visual acuity as well as metamorphopsia score. Another entity which is the central bokeh abnormalities, which can range anywhere from the subretinal fluid accumulation, cotton ball sign, as well as the vitelliform deposits. These are some of the abnormalities one tends to see. This also basically occurs due to the Muller cell stretching and inversely correlates with the EIFL thickness and tends to have a worse visual acuity. And the mean metamorphopsia score correlates significantly with the ectopic inner foveal and central foveal thickness, but not so with the central bokeh abnormalities. The another thing which has been described, what is known as the Dyspholia vascular distance, which is nothing but this is the fundus at baseline, this is the fundus at follow-up. So overlap both these images. So measure basically A1, B, B1. A means distance from the disc to the fovea, and B is distance from the fovea to the upper arcade, C is distance from this. So you add all these values, you tend to get a disc foveal distance, which gives an index known as the tractional index of the membrane. So one tends to have the prognosis can be assessed by this. So drill is another entity, the distorted retinal inner layers, which is also a good biomarker for the predicting the outcome. Autofluorescence, of course, if you tend to see an enlarged hypofluorescence, which indicates that which is a poor prognostic factors, so tends to have a correlation with the visual acuity. OCT angio, the FSZ area tends to enlarge. The less expansion of the deep layer foveal avascular zone tends to have, this indicates that some patients have a lack of improvement of metamorphopsia or anisoconia after surgery. So there is a correlation with the FSZ area and the visual acuity recovery. So one can also detect what is known as the vessel length as well as the branching point distance. This is the vessel length and the branching point distance. These two parameters also helps us to assess the correlation by Octa. Choroid, definitely choroidal changes have been documented in epiretinal membrane. They have been shown that Sattler's layer perfusion may be a useful marker for this thing. Even the choroidal scleral interface index is also a good index for assessing the outcome in ERM patients. Fluorescent angiography, those patients who tends to have a fluorescein leakage tends to do poorly when compared to those who doesn't have. So ILM dehiscence, this is also associated with increased interretinal tear thickness and tends to have a worse visual outcome. Schisis, sometimes schisis can be protective. But the only thing is those who are associated with foveal schisis tends to have a more post-operative foveal macular edema. The ERM with shorter axial lens tends to do poorer when compared to the longer axial lens. Of course, subretinal Rusinoid deposits. Foveal herniation doesn't have a much impact on the outcome. So multifocal ERG shows that amplitude and implicit time of positive peak wave significantly correlates with the post-operative visual acuity. So in summary, younger the patients, shorter duration of symptoms, higher the visual acuity, lower the metamorphopsia, lower the central foveal thickness, and outer retinal layer intact, and the autofluorescence, especially hypoautofluorescence. All these are the good prognostic factors, but one need to look into the two important factors. The one is the inner retinal irregularity index and the ectopic inner foveal layers. These are the two important factors which assess the outcome. Thank you for your patient hearing.
Thank you, Sunil. Do we have any questions for Dr. Sunil? Dr. Sunil, do we have any indicators for the point of intervention of ERM surgery? That is, if you see this particular biomarker, does it mean that this is the right time to operate?
Operate and wise, the one is the metamorphopsia score I consider on the visual acuity.
Okay, so if you have a 6/6 thick membrane on top, that is not an indication for surgery.
Depends upon the presence of other indicators also, like ectopic inner foveal layers or other things because they tend to progress sometimes. So better to operate in them. But vision acuity is an important criteria rather than the OCT biomarkers alone.
Okay.
Is there any indication where you would not prefer to touch the patient?
Okay. Secondary membranes, especially idiopathic membranes, tends to do well unlike the secondary membranes because there could be an inflammatory component like diabetic membranes and other things. So if the visual acuity is good and if it is a secondary membrane, sometimes I look into the other factors than the visual acuity alone.
Excuse me, sir. I have a question. While you are operating on epiretinal membrane, these kind of cases like ectopic foveal layer, so do you recommend to peel the ILM along with the epiretinal membrane? Does it help in prognostic outcome as far as the vision is concerned?
Yeah, the recurrence rate will be less, but it is not mandatory to peel in all the ERMs. But definitely the recurrence will be reduced, but the ultimate outcome in a long term probably may not.
So do you recommend ILM peeling?
Not in all cases.
Thank you.
Yes, sir. For functional assessment, definitely yes. You can consider pre-operatively. Yeah. I forgot about another biomarker. Recently, I saw one of the papers also presenting things. Diabetic ERMs, one need to look at the hyperreflective foci also. They showed that those who tend to have an hyperreflective foci, they tend to have an inflammatory component also. In spite of a good peel, they may not improve in some other cases.
When you have now with BBG and all, the peeling of ILM is so easy. The plane of the ERM, which may be invisible, this double
staining, yeah, definitely.
Double staining, and along with the ILM, actually, if you find difficulty in getting the plane of the ERM, start the ILM peeling, and that brings the ERM along with it. Actually, yeah, so it doesn't take much to peel first ERM and then ILM. It comes together.
You will be rather tempted to peel.
Yeah.
Thank you.
So we have the next speaker, Dr. Unnikrishnan R. He's a medical director and managing partner for Chaitanya Group of Eye Hospitals. So, and he's an excellent clinician and academician. So he will be speaking to us about the predicting surgical recovery and visual outcomes after macular hole surgery. Unni, to you.
Thank you, George. And we started with the ERMs and then we're coming to macular holes. So macular hole surgery is rewarding. but often you're dealing with good vision, so you need a tight control of what comes out of your mouth, what you tell your patient, and therein lies the necessity of giving good, worthy promises to the patient. And the decisions are basically based on the knowledge you have. Imaging biomarkers have come to the fore in that. So this is a classic, I'm not going to touch it at all. So basically the first question, do macular holes close by themselves? So that is the first point. Stage 1 holes, you have up to 50% of stage holes can spontaneously close. So what that means is that when you see a macular hole, there is an importance in knowing the staging and the closure rates. Well, as the stage progresses, the possibility of closure and your intervention becomes higher. So how can you predict the closure? This is simple. Smaller holes close faster, larger holes the closure rate comes down. So I'm just going to skip these 2 slides. And so next, okay. This is just what this is, there's no biomarkers here. You're just 2 pictures here. Without even looking at anything, you get the feeling that the hole on the top is not going to close and the hole on the bottom is going to close. So this is intuitive for you. Okay, so this is barring anything else, you have some intuitive knowledge here. Rectilinear square holes with no SRF, the chances of closure is less. This is something that goes into your brain. Ones with acute angles with cystoid macular edema, a bit of SRF, the higher the hole, the chance of closure is more. So based on these observations, all the studies, the parameters, the macular, the things come out. Again, when you see the hole on the top, you see a bit of operculum still attached, just as if it's just come off, you know this is going to close. The chances of closure are more. This is not based on, this is based on the surgeon's gut instinct. We have not reached biomarkers yet. So we have, like Dr. Sunil said, the lesser the duration, the better the vision, the more chances of a hole closure and better post-operative vision. Add to that the stage of the hole and the size of the hole. These are the 4 simplest parameters we get from looking at an OCT image, talking to the patient for about 5 minutes. But for all practical purposes, the most important measurement is the minimal inlet diameter. That is the closest points between the edges of the hole. And based on that, holes are divided into 250 to 400 and less than 250, more than 400. It's funny because we see all these measurements, and when we start measuring, we see only things greater than 1,000 and 700 and 1,000 and all those things. I don't know where this 400, I haven't seen a 400 micron hole for a very long time. They don't come to my clinic, okay. So there are loads of studies validating this particular point. Minimum inlet diameter, the most important measurement. One measurement, find the closest. Now I'll tell you there's a small fallacy in this later. Then you have there's another study saying minimum inlet diameter. And we have a host of indices. These host of indices, it's addictive. When you see a macular hole, you look at what has not been measured, can I make an index out of it? And I have also done that. I'll show you what I've done. So these are the typical indices. You have, basically what it does is incorporated the height of the hole to the base of the hole. And because you think of something collapsing and falling, the bridge closing, and you're imagining that the higher the hole, the more likely the sliding and the touching comes. That's what you're imagining. And all these indices. So you have one study that says one indice is good. The next study said this is better. The next one says this is better than both of them. The third one is an addition of the first, second, and third, and that's the best. So we practically do not use this much. So this is all the indices. We'll take a question who uses it. But this is interesting. ELM gap. That is, you're going beyond the hole closure. That is, you're checking how much the external limiting membrane, which is the most critical, that is the Muller cell representative, the most critical, whether that will close or not. So that is the minimal ELM gap. If the ELM gap is closer, the chances of the ELM gap closing and having a better post-operative result is higher. The whole inlet diameter may be smaller, but your ELM may start retracting way ahead of it. And in that case, you'll have a large defect in the end and the visual acuity will be poor. So this is an example of that. That's your ELM defect, and it's very close to the edge of the hole. And when it closes, your ELM starts reforming. You can see the ELM starts reforming very close to the edges in the beginning. This is a very close second or third post-operative week picture. So when the ELM gap in this set is slightly away, when the ELM gap is slightly closure, it is indicated that the hole didn't close and the ELM was very far away from the edges of the hole. So this is our fiddling with the ELM gap. We did something called the ELM angle. trust me, it is just fiddling with the same thing. So we incorporated the height also into the ELM angle, and we took this particular angle between the height of the edge of the ELM and the space of the ELM, and we found that the more acute it is, the more chances of the ELM approximating. That is, we got a degree of 68 degrees. Anything less than 68 degrees in acute angle, the ELM approximated much better. So we just fiddling. We first saw something new, we went for it. That's it. This is something that is started off very promising. Pre-operative choroidal hypertransmission. Whenever you see pre-operative choroidal hypertransmission is less, it's good, it's more, it's bad. But when you look at it critically, if the hole is open, the choroidal transmission is more. So this indirectly was just another biomarker talking that if you had a larger hole, you had a larger transmissible choroid. So after this wonderful study, the last line was it may not be a good imaging biomarker. So this is something I'd like to, I'll just go to this, NFAS OCTA. So this is something that is really piqued my interest. The NFAS imaging of a macular hole. So we looked at two aspects. One was the Octa, the FAZ size. Funnily, or not funnily, the FAZ became more normal after a macular hole surgery. Why was that? Because the cysts went away. So the distance between the vasculature shrunk, and it looked like a functional improvement, but it was actually a structural improvement that was happening. And the next thing we looked, this is our paper, we looked at the cysts. There were a couple of studies about the perifoveal cysts. This is a beautiful looking images I'll just show you. This is how the cysts around a macular hole look in what do you say, on-fast OCT. What we did is that we did manual segmentation, and we discovered there were two types of cysts. Basically, you had your inner nuclear cysts, which were larger and smaller area, and you had your outer plexiform or layer cysts, which were dot-like, smaller, but extended in larger area. Funnily, it was inversely proportional. The larger the hole, you had smaller area of cysts. The smaller the hole, you had larger area of percentage of cysts. So there were two theories. One is called the hydration theory. That is, the larger the cyst, more area, it gets hydration. We proposed a new theory called the RP contact theory. The cyst correlated well with the basal diameter. That is, when the RP was not touching the base of the hole, those areas had a lot of cystic areas. And this correlated with, phenomenally, the inner nuclear cystic area correlated with the post-operative visual acuity a lot. This is how we calculated, we binarized it, we divided it into outer layer, inner layer cysts. And this is another point I'd like to say. When we measure the minimum inlet diameter, you just measure across. But when you take an NFAS image of the minimum inlet, you find it's all different shapes. It may be just 300 or 400 in one diameter, but the other meridian, it could be 600 microns. So what happens is that all your indices are taken for a toss slightly. When you do an NFAS, it is not just the 180-degree linear thing you're measuring all around. It is not 400 or not 500 over there. This is another picture that actually shows the base shows the amount of ellipsoid zone loss also, the black area, which tells you there's a large area of ellipsoid. So NFAS imaging of macular holes, I think, is a really exciting way to go nowadays. So we just look at a few post-operative factors. We know what a flat open is. A type 2 is worse than a type 1. In the U, V, and W, we know the U closure is the best and all those things. So I'm just going to go quickly. The ellipsoid zone integrity, very important. There are many different ways of ellipsoid zone, and I'm saying that the best way to measure the ellipsoid zone is using NFAS OCT. So two other things is the Sanfil and the Donfil, swelling of the arcuate nerve layer, and the next is the dissociated, the dissociation has a temporary visual loss after macular hole surgery, and this is what it looks like. You can see a picture with all those small wrinklings on the top over there. And again, when you do an NFAS, you get this very nice picture of hexagonal patterns around it in the entire area where the ILM has been peeled. So this is an NFAS image of Donfil. So we try to compare Donfil, the appearance of Donfil, with the direction of peeling, whether it's more nasal and temporal. The only thing we found, the Donfil is greatest in the area where you initiate the pinch. The quadrant where you initiate the pinch, that's where we found the highest amount of Donfil changes. So there are other things like having inner layer hyperreflectivity doesn't mean much, not much was found out of it, but this is important. Ilm Flaps. we use Ilm Flaps to show the patient after a week that we've closed your macular hole. There are 2 types. That's a stuffing technique and the cover technique. Basically, the cover technique is what is getting important now. Putting things inside the macular hole, it is not meant to be. So this is what you can see. There's a hole, or it looks like an astronaut standing holding the 2 edges of the macular hole together. You can see that. So do not put unnecessary things inside the macular hole. That is, so cover the macular hole up. This is another, this is keloid. We think it's, we're going to call it keloid. So after a macular hole, you get all this undiagnosed tissue growing in the macular hole. So basically, it is not, it's all I have to say is that the ILM plug is a negative biomarker for visual acuity, okay? So these are the other things about NFAS imaging. You see, pre-operatively, this gives you the amount of, the upper top right image gives you the amount of ellipsoid zone loss. And post-operatively, you can still see it. It has come down. So NFAS as a tool for imaging ellipsoid zone is brilliant. This is something that we did also. It was very interesting. We measured pre-operative center of the macular hole and did it post-operatively with the edges to the mesial markings. And we found out that there was commonly a shift of the center of the macular hole. So the macular hole usually shifts temporally, but some of them usually shifts nasally, but we had about 15% shifting temporally. We couldn't find a statistically visual significance to that, but it could mean something in the future. The last point I'd like to say is that ONL thickness, cystic spaces have a relationship to metamorphopsia, the metamorphopsia scale, so that could be important to talk to. So it is not only about closing macular holes nowadays, but it should be about closing macular holes and doing just the right amount of work, not to give them a worse or an equal post-operative visual acuity. Macular holes close, you're just helping them close. Okay, so that's what I'm saying. Most of us know that when you go inside, for small holes, don't do ILM peeling. You still have to just think that maybe a vitrectomy might do. And do not be afraid to tell the patient, I'll try it one more time with ILM peeling at the second go if it doesn't close with a simple vitrectomy. If you have a very small hole, please try to do it without a ILM peeling. There's nothing that says that if the ILM is there, I will peel it. Okay? Thank you very much. And again, inviting you for the Retina Imaging Congress on the July 22nd and 23rd in Toronto. Thank you.
Unni, I have a question for you. Do you leave any, we have heard about micromacular holes, probably the one which they grade as less than 250 microns now. Earlier we used to call less than 400 microns as micromacular holes. So is there any holes which you would observe and wait for a spontaneous closure, or do you even for a micromacular hole, or if it's waiting, how long, and do we go for a vitrectomy surgery in such scenarios?
Okay, when I talk about micromacular holes, I'm usually thinking of those very small 50-60 micron defects punched out in the outer layer. But anything less than that, let's say a small macular hole about 250, I always try to look at the vitreomacular status. When you look at it, you have an idea whether is there some chance of it trying to elevate, or is there no chance of it trying to elevate. You can there is, I think, a parallelism index also. When it is very parallel to the retinal surface, the chances of it detaching are less than when it has a more acute angle. So some cases I do it, but these are the cases in which I do not like to do ILM peeling. Sometimes I just let it go with just a vitrectomy and air, or just a vitrectomy and a little bit of gas, and I try to see if it closes with that.
And regarding the stuffing, suppose you have a failed macular hole surgery, and you have an open hole.
Yes.
So at that time, do you consider stuffing, or what would be your technique?
No, if I peel the ILM, and I can get some ILM, like a pedicle from somewhere, we've tried it. But interestingly, I don't know how this is, but second surgery is use of silicone oil. Closes a very high number. In the study meta-analysis say silicone oil for persistent or failed macular holes has a nearly 100% chance of closure, and near 100% chance of closure. So for me, rather than finding ILM, I try to find ILM. You get tons of ILM, one strip, just the edge of it goes and touches the macular hole because there's no ILM left. You've already peeled off most of it. Free flaps are never successful. I can't get them to stick inside.
Yeah, actually what we do is like under the PFCL, we peel the edge of and drag it and put it, otherwise it will fly off. So, and with gas, maybe silicone oil is a good tamponade. Anything to add, madam?
Yeah, wonderful presentation, Uni. I agree, any kind of foreign material in the hole actually is a negative biomarker. So I have just a personal observation, sometimes if you use triamcinolone to stain the vitreous and you have few drops of it or crystals of it going down, that itself sometimes impedes the closure of macular hole. I don't know if you have also experienced that.
That's there. And also, the funny thing is that I don't know when whether there's a wonderful paper that says that triamcinolone is directly toxic to the RPE, triamcinolone crystals. So having an exposure of triamcinolone, that's why all this hype about putting a bubble of PFCL inside or something inside before you use triamcinolone. Crystals of triamcinolone are toxic to the RPE is what one major study has said.
Yeah, so basically there should be nothing in the hole when you are covering it with ILM. So a little bit fluid which is sometimes present, if I have to suck it, I just suck it just before the FG because it has to be done under good visualization and then cover it with the flap and not disturb it at all.
And that's why now the temporal trapdoor flaps have come into being, just a small temporal trapdoor. But one thing about the trapdoor flaps and all this thing is that do not try to manipulate the flap till you've done an FG. That's the best way to do it. You do it after once you put it over there, you do the FG, it goes away, then it comes back, it moves here and there. So instead of touching and flipping and flopping the flap, you just leave it to the last minute and just brush it onto the...
The trick is to have your flute on the opposite side of the hinge.
Yeah.
So that takes care of it, that's all.
If you are not using a hinged flap, do you keep the ILM and do you do anything to retain it over since we are not stuffing, do you do anything to retain it over the macular hole after the FAE?
After FG, I just drop a little drop of Visco over it.
Yeah.
That does my job. And I don't have to stain it because after FG it is a beautifully well seen under air.
Okay. Sorry.
A question.
One is any recommendations based on imaging about the size of the diameter of the ILM beam?
No, there is, I'm sorry, the second question also?
Second question is a repeat of the previous presentation. When will you not operate the macular?
Yeah. May I take the second question?
Please do.
No, one is chronicity. 1 year, 2-year-old macular holes and vision, poor vision. And then you have to, even if you take and very large holes, even chronic, and you see this, whether with autofluorescence, or you see a lot of RP degeneration at the thing, these are very large holes. So, see, these would be the poor markers. If patient is bent upon surgery, then go ahead. Otherwise, leave it alone.
So there are two studies based on the size of the macular hole. One says 1,500 and one says less than 1,500. And there's another study about 750 and less than 750. In both the studies, they end with the results saying there is no change in visual acuity, but the hole closure is better in the larger macular peel. But the one study, the second study says, however, that is the interesting point, the post-operative metamorphopsia is less with a larger peel. So these are the two results of those studies. And it's very small groups, very controlled, but these are the two studies that says how it is.
I think now we have reached a point that we just use ILM to cover the hole. So if your ILM flap is enough to cover the whole size, then I think the larger peel may not make too much of a difference. Only thing that I try to focus on is that I make sure most of the edges of the hole are free of ILM. So apart from that hinge that you are keeping, the rest of the edges, so that helps relieve the traction. Other than that, arcade to arcade ILM, I don't think that works.
Thank you, Unni, for the good presentation, and we had a good discussion. Next speaker is Dr. Muna Bende. She is a director at Shankar Netralaya, Chennai, and excellent clinician and teacher to many of us. So she will be speaking to us on predicting progression of dry age-related macular degeneration and its significance.
Good morning, everyone, and thank you, Unni, for inviting me. I think this is probably the only talk of the session which is based on retrospective studies, and it's only something that is planning for the future. the natural history of geographic atrophy progression, most studies give it over a period of 4 years. And they show that there is a change in lesion size, but it basically depends on the number of lesions, the shape of the lesions, and their location with respect to the fovea. So atrophic lesions with a diffuse, linear, or banded autofluorescence pattern seem to grow more rapidly. So if you look at this picture, when they show various patterns of autofluorescence and look over a 2-year period, you find that cases with banded autofluorescence, cases with diffuse or trickling autofluorescence tended to grow more than areas with no or only focal autofluorescence abnormality. And then we also have a factor that says that the growth is strongly related to the lesion perimeter. So you have the same area, but you have a round lesion and you have an irregular lesion, and the irregular lesion grows more. So if you look at this little graph shows it very nicely. And this is one of my own patients with an irregularly shaped area of geographic atrophy. You look carefully, the advantage of your autofluorescence is that you see the entire lesion en face. And you see these slight, subtle changes here. You see this little tail growing here over a 1-year period. You see a little bit of increase here. So this is the benefit of autofluorescence imaging when you do when you're looking at progression of geographic atrophy. So there are other precursors and that are related with the development of geographic atrophy, and basically minimum change autofluorescence tends to progress more. And this is an interesting graph that shows that at the start of the study, when there was very little autofluorescence changes, you see how many of them progress to atrophy at the end of the study period. And these, again, like I mentioned, most studies are retrospective, looking at the end point. This is the final visit, and here you see this irregular shaped lesion, this multifocal lesion, is growing more than the unifocal lesion. This is again my patient. Here you see, you decide this is the fellow eye of the patient. You see this small area of geographic atrophy. You see this little tail increasing. There is surrounding area of hyper autofluorescence. And you see that over a 1-year period it increases more. And then this is just a few months later when the patient said, my vision is getting worse. I did the autofluorescence imaging, it looks the same. He basically had developed PCO pacification. He was pseudophakic. So, yeah. So what are the precursors? Most of these studies give you a time frame of 4 years. I don't know whether it's coincidence, but a lot of my patients also have seen progression at 4 years. So what are the earliest changes? Early local photoreceptor changes and drusen accumulation. These are the highest risk of progression to geographic atrophy at the end of 4 years. And they precede other anatomical heralds such as RP changes and changes in the drusen substructure. Again, this is the CAM study. A lot of talk has gone on about it. In India, we see very little of geographic atrophy, so for us, maybe a little theoretical. But yes, they have identified certain features that are at risk for atrophy development, like hyperreflective foci, drusen, and subretinal drusenoid deposits, formerly known as reticular pseudodrusen. This is a very interesting review article that I found, which aimed at evaluating the status of OCT biomarkers for prediction from intermediate to advanced AMD. And they looked at all these various factors. Most of it were changes in the outer retinal layer, seeing the continuity of the external limiting membrane, disruption and thickening of the retinal pigment epithelium, changes under the drusen hyporeflectivity. Here you see difference in character of the drusen from homogeneous to heterogeneous. And these are features of reticular pseudodrusen or subretinal drusenoid deposits, which currently are, I believe, to be at the highest risk for geographic atrophy development. And these were the various parameters they looked at, and they found that the predictors of conversion to atrophy, the highest was drusen collapse. And I'll show you some of my own patients where drusen collapse was seen. Now, when I said we need to look carefully, sometimes you need to use these multiple line scans to look for individual areas of change. Right now more of theoretical, but if you look at all these subretinal deposits, you see one that is looking a little different. There is some hypertransmission, and there is some amount of deposit above the lesion. And you see a few months down the line, this is about 1 year down the line, you see this area has collapsed. There's collapse of the outer nuclear layer. So you would need to definitely look at these images very carefully to see how things progress. And this is another patient. You see this is 2018. You look at this drusen. In 2019, you see now that there is this small hyperreflective dot. Why is it important? It's because it's close to the fovea. This is not a sign of progression to neovascular AMD. This is a sign of progression of geographic atrophy. Sometimes you see the Rusinoid pigment epithelial detachments. You see this patient 2017, 2018. So it's 2018 and suddenly came in 2019. You had an enlargement of the Rusinoid PD and then suddenly it collapsed. So an increase in size of the Rusinoid PD suddenly does indicate that this is going to be collapse at some time or the other. And this is another interesting feature called drusen ooze, which is a novel hypothesis in geographic atrophy. Why is it important? It's because we can sometimes mistake it for neovascular AMD. This is a patient with a small drusen, and you see after some time the change in character and the lesion collapses, giving rise to atrophy. Now, identification of an acquired vitelliform lesion, this is part of non-neovascular AMD, and it's important because it can very often be mistaken for neovascular AMD, the reason being the presence of subretinal fluid and this area of RP thickening. This is one of my own patients, and this highlights the importance of OCT angiography imaging. You see this vitelliform lesion at the fovea. The OCT angiogram shows no neovascularization, and you see later this lesion has collapsed without treatment. Now this is a lady who's 90 years old, and I've been following her up for many years. She has dense asteroids and vision of 6/6 with advanced glaucoma in both eyes. And you see how her Rusinoid PD increased in size. She has a little irregularity of the surface here. This is the fellow eye. Again, you see the Rusinoid PD increasing in size. Now with swept source, we are able to see the content of the drusen, content of the PD. Suddenly one day, this PD increased in size, and the next visit it had collapsed. But if you look carefully, the outer retinal layers are intact, which is why she still enjoys 6/6 vision, but with a tubular field. So sometimes Rusinoid PDs collapse without causing much of a visual loss because the outer layers are intact. This is her other eye. The lesion is increasing in size. There's some changes on the summit of the lesion right now, and I would expect probably her next visit, this lesion would have collapsed as well. So this is an interesting reference which says that RP death is linked to the lifestyle of Rusinoid pigment epithelial detachments, and it's heralded by a sudden increase in size and then collapse of the lesion. And this is exactly what we saw in our patient. This is a slightly younger lady, and she had these large serous pigment epithelial detachments at the fovea. You see some pigmentary changes at the summit. And this is what we need to watch for, this cap of subretinal fluid on the surface. This is part of the drusen ooze hypothesis. This is not a sign of neovascular AMD. She developed it in both eyes. And this was the picture. You see the autofluorescence changes more obvious in the left eye, and the next visit the lesion had collapsed. This is a subsequent visit, and then finally this is the last visit when she saw me a few months ago, when we see that the PD in the other eye has also collapsed. This is heralded by the leakage or the ooze of Rusinoid material into the periphery, leading to the lesion collapsing down. And this is her fellow eye. Sorry. And this is probably the longest follow-up of one of my patients from the year 2007 to the year 2019. You see this lesion in evolution, and what happens during each process is these little discontinuities on the summit of the PD with areas of subretinal fluid. At each time these close, the lesion collapses, there is a change in the content of the Rusinoid PD, And finally, here you see that much better, these multiple little gaps in the pigment epithelial detachment. Finally, from 2019, the lesion is now flat. His vision is poor because he has outer retinal atrophy as well. This is both eyes of a patient with non-neovascular AMD. You see pigment epithelial detachments with pigment proliferation on the surface. This irregularity or thickening of the RP should not be mistaken for CNVM. And this is the fellow eye where you have a little nodular changes on the surface with hypertransmission as well. If you look at the progress of this lesion, you see that the patient had developed small areas of atrophy on the summit and overlying areas of cystoid macular edema. And this was actually retinal pigment epithelial aperture, which is one of the stages in evolution of dry AMD and not related to choroidal neovascular membrane formation. And these are two references on that. And this was the left eye with multiple apertures, eventually went on to atrophy. For the right eye, just a moment of caution. When we get so excited about atrophic AMD, we may sometimes forget there are biomarkers for neovascular AMD in the same eye. This is the same patient. You see the right eye, as the lesion flattened, you see some changes nasal to the lesion here, some amount of hyporeflectivity under the Rusinoid PD that eventually, over a period of time, you see this lesion as you follow it. Oh, I'm sorry, I'm missing a slide. You see this lesion after some time developed a small neovascular membrane. So as the lesion flattens, there is sometimes the occasion of conversion to neovascular AMD at the borders. Yeah, and this is what was the end point. Patient had a large choroidal neovascular membrane. Outer retinal tubulations are other biomarkers for atrophy. They're at the border of the atrophy. They may be protective in terms of neovascularization, but areas of outer retinal tubulation are believed to limit the areas of atrophy, as you see in this beautiful slide from this demonstration. And we cannot leave OCTA far behind. Areas of choriocapillaries flow deficit are believed to be early biomarkers for geographic atrophy development. So this is my last slide, and I would put this as a disclaimer. The current relevance is mainly planning of protocols and endpoints for clinical trials, because we have such good imaging now that we are able to see this. We have data for many years in retrospect. So these are the main precursors for progression of atrophic AMD, something we are likely to hear more about in the future. Thank you so much for your patient listening.
Thank you, ma'am, for that wonderful talk. Do we have any questions, please? Yes, please.
So the follow-ups? Yeah, I was seeing her about 4 to 6 months with an Amsler. She's 94 right now, so it's difficult to get her in, but well educated and able to follow up with the Amsler. When the drusen PD increased, actually she had gone to see someone else who suggested an injection. She got worried and came and saw me, and then the next visit the whole thing flattened. But 4 to 6 months with an Amsler should be fine.
Good morning, ma'am. Good morning, panel. So the question is, when we are trying to predict the recovery rate for these diseases, there are patients who are lined up for the cataract and they already have these diseases, and the patient doesn't want a cataract surgery or he doesn't want a macular surgery. So for example, in a GA patient or in a ERM patient, he says, don't do my retina treatment, just give me a cataract surgery. And he's insistent on that. But then we have to follow him whether he is progressing or he is stable. That is one part. And after cataract surgery, we need to redo the whole investigation and check whether he has progressed. So I just need a comment on that.
I think probably we tend to use PAM, and that gives a fairly good prediction. Cataract surgery is not a contraindication, definitely, even if the patient has geographic atrophy, and especially if they have poor vision and a dense cataract, it will definitely improve the quality of vision.
Yeah.
So as long as we tell them that, then I think they're okay with it.
And
but we can't promise them perfection.
Right.
And if cataract evolves during the course of your follow-up, then it's easier to convince them. It's the first visits that's the problem.
So maybe for an in a case of ERM, maybe we can do a surgery and we repeat the test and show him the biomarkers.
Yeah, no,
Ilm?
basically for ERM and macular holes, I mean, it's slightly different. The indication for surgery for macular hole, if it's there, you are advising surgery. If the patient doesn't want, then you are doing a suboptimal treatment, whatever it is. Then everything after that is makeshift. Okay.
Correct.
Now coming to ERMs. So ERM is one condition in which you have, let's say, a 6/9 or a 6/12 ERM with a cataract. I have advised cataract surgery for some people, and I assess the vision after that, and I offer ERM surgery unless it is very heavily distorted. If it's just a foveal elevation, a foveal straightening, it's just an option. I'm not saying that. I mean, ideally you should treat the macular condition. The concept of treating the macular condition, the concept of the cataract surgery are two different that get integrated at some point of time. Okay, George.
I just comment on that. Many times people have OCT as part of their pre-op package when they're planning a premium IOL. And that's when the confusion sometimes starts. You see a little bit of thickening. Patient really doesn't have much problem as far as the vision is concerned. So if it is just a finding on the OCT, and clinically you feel that it's really not that significant, you can probably would be cautious about saying I'll do a multifocal. But otherwise I think it's okay to wait, because many of them are quite happy with the vision after cataract surgery.
Yeah, phasing in two phases. First, it would be a good option, I also feel. I have a comment on that beautiful case where the Rusinoid PED had subretinal fluid, and do you consider at that time any OCT angiogram? I mean, do you consider a subclinical CNV in Rusinoid PEDs when you see a subretinal fluid, like for the audience? Do you or just observe these? Thinking that this is the transudation from the RPE defects that you see?
I'd probably be looking more at an OCT angiogram if I'm seeing the fluid at the sides of the lesion rather than on the summit. And if the fluid is associated with just some pigment, it's a small gap of fluid at the summit of the PED, then I may not do an OCT angio. And when you have these highly elevated lesions, you also have to keep in mind the segmentation artifact that will come, because then, very often it may be mistaken for a CNVM. So
why I asked is, even we have seen some of these, not at the apex, proper subretinal fluid in the presence of Rusinoid PEDs, and ICG angiography do not show any neovascularization. Even Octa, as you said, the segmentation problems and doesn't show any thing. So probably we observed the patient because we didn't get anything on ICG angiography. So that
probably the most important area, like the acquired vitelliform lesions, those are the ones when definitely we would recommend to investigate more.
Thank you, ma'am, for that. I'd like to invite Dr. Rajni Bhattu, who is a senior vitreoretinal surgeon, and she has a keen interest in genetics and hereditary disorders, and runs a wonderful institution called iStem. Am I right, ma'am?
Yes. Morning, everyone. Thank you, Lee. Thank you for that. Thank you for the invite here. Yes, I'm part of. I have a startup called iStem. That's not the point of discussion here. So, predicting prognosis and diagnosis in retinal dystrophies, that's the topic. And so I'm going to look at first the diagnosis, and then we'll look at the prognosis. And this is, I think, especially important because most of us end up having to tell patients that the prognosis is not great, and so it's important that we know what to tell them. In terms of diagnosis, so we look at three things. One is the okay, so that doesn't work. All right. So the clinical imaging and the genetic markers. I'm just going to start with a couple of cases. The first one is, thank you. Yeah, the first is a 8-year-old girl, a very soft-spoken girl, who presented with decreased vision over a few months. The father gave the history that she was struggling to read. There was some history of fever prior to that. Her best guide vision was 6/18. And anti-segment normal. The fundus had been reported to be normal over 2 examinations. So a possibility of malingering was being considered, and a psychiatric opinion sought. So this was the fundus, more or less normal, except for probably some heightened macular reflex in both the eyes. And that's the infrared image, which shows something similar, whereas the clincher is the autofluorescence. So you do see that there is a significant loss of autofluorescence at both the maculae. And when a OCT is done, there is a considerable amount of ellipsoid loss all through the macula, except for this nasally in both the eyes. So this patient, the ERG was normal. And so what did this child have? So this is one of the classical presentations of early onset Stargardt macular degeneration. So this child actually had two homozygous mutations, two mutations in the ABCA4 gene that does cause Stargardt. And so early onset Stargardt is especially something that's very easy to miss. I must have seen at least about 6 to 7 children in the last few years who all get diagnosed with other things and go from for multiple consults. Simply because simple autofluorescence or OCT is not done. The importance of history again, this is a 6-year-old boy who was referred for a routine examination by the neurologist. So this child was being treated for infantile spasms and subsequently epilepsy, had some amount of developmental delay. The parents were very keen that they have a second child. A whole exome was done by the neurologist, and it did not show anything. No mutation was identified. So referred for routine examination, but when persistently asked, the parents did feel that there was some vision difficulties. I think especially the last 2 years, many of these children sitting at home, parents have struggled to identify whether the child has a vision problem and so on. So the best cut vision was 636, anti-segment normal. And the fundus, again, in this I think it's a little easier to make out that there is some changes there. And autofluorescence is obviously significantly altered. And the same with the OCT, significant loss of the ellipsoid zone throughout there. So in view of the new findings, we decided to reanalyze the same sample, and this is what we found. Here we not only found that the child had 2 mutations in ABCA4, the child also had a mutation that caused the systemic problems. So this was called the SPTBN1 mutation associated with multiple systemic problems. The take home here is that a complete phenotype is a must. So doing a genetic analysis without a complete clinical information is absolutely not okay. So you cannot interpret a genetic testing without a complete phenotype. There are a couple of specific signatures that you can notice. So in this, for example, this is a young man who's got the classic coats-like response. There is also some amount of this clearing around the vessels that you see of the RPE. And then you have the classic pigmentation. So this is, so these people also have a very thickened retina with significant loss of the retinal lamination. This is very characteristic of a condition called a CRB1 mutation or a Crumb's homologue. And so a complete examination is a must. So this is a young man, completely normal retinas, normal fundus, normal OCT, except when you look at the periphery, you see this. You see these large areas of pigments. So this is a form of Best disease. It's called autosomal dominant vitreoretinopathy. So a complete examination, clinical history, all of that is an absolute must. This is something that's known. A young child, 11-year-old child presenting with drusen with a normal OCT. These are very classic of a condition called membranoproliferative glomerulonephritis. This child incidentally went on to develop renal failure subsequently. So what do we do with the prognosis? Again, we look at the same 3 patterns. We look at the clinical bit, the imaging, and the genetic information. The age of onset is extremely important in these patients. The earlier the age of onset, generally they are a lot more severe and the progression is a lot more rapid. And whether they're associated systemic conditions, that's extremely important. And how have the other family members fared with the similar condition? I think the commonest that we use often across the board is OCT and autofluorescence. And so obviously, this if this is a child who presents with this is about a 9 or 10-year-old child where you see a significant amount of ellipsoid zone remaining, versus this is a child similar age but something called early onset retinal dystrophy, you would definitely know that the prognosis here is much better than this child. So autofluorescence, I think Tony Robson from Moorfields did a lot of work on this. The loss of autofluorescence and the progression constriction of this ring becomes an extremely important marker to understand prognosis. There are algorithms that can help us, especially in situations like Stargardt's and so on. This is a girl I have seen between, a young girl, about 14 years old, in 2016 and 18. So if you look at the ellipsoid zone, you don't notice much of a difference. Whereas, over a period of time, you do notice that, so there is a significant loss of the ellipsoid zone. Today, there are computer algorithms that can do for this. We don't have to do this manually. Especially with Stargardt, a lot of work has been done in terms of the prognostication. In terms of, so there is one way to do it, with use of ERG. If your full field ERG is normal, the prognosis is actually very good. Sometimes the cones, ERGs get involved, and if both the cone and rod ERGs are, affected, then the prognosis is much worse. So based on the fundus autofluorescence, Fujinami sort of, described how this can be seen. So this is, for example, a type 1 autofluorescence where you have a localized loss at the macula, but the background is generally homogeneous. So that's a type 2 where you have a localized loss at the macula, but the background is considerably heterogeneous. And the type 3 where the loss at the macula is just not just focal, but multiple of them, and then a generalized, heterogeneous background. So obviously, it is the increasing worsening of, severity. We do look at multiple others, including the fields, ERG, adaptive optics, microperimetry, and so on. And how do we look at in terms of genetics? Does it really make sense? Do we understand, how severe a mutation is? Can we prognosticate based on the results that we get? So as a rule of thumb, X-linked diseases, X-linked retinitis pigmentosa is the worst of all. That has the worst prognosis, followed by the autosomal recessive inheritance. Again, generally, autosomal dominant diseases tend to do much better than others. In terms of the actual mutations, nonsense mutations are generally more severe. I'll just show you an example of what that actually is. So in terms of macular dystrophies itself, some of them actually tend to do well in terms of, like achromatopsia. It's a stationary disease. Youngsters presenting with pattern dystrophy, not too bad. Juvenile retinoschisis, as long as they don't have bleeds or a retinal detachment, they're not too bad. Best, of course, autosomal dominant is, definitely okay. Early onset Stargardt, like I said, is probably, quite a severe disease. I'll just take a few seconds. So what does a nonsense mutation, mean? So when you look at a mutation like this, here, the arginine amino acid here has been terminated. So when a change in the amino acid creates a stop codon, there is no formation of the protein from that point, so it's called a nonsense mutation. That's much worse than what you would see, for example, So for example, in, something like, sorry, I don't have an example of that. Okay, so if there is just a change in the codon with, there's no stop codon being initiated, that's called a missense mutation. So they tend to do much better than nonsense mutations. So there are very specific mutations, for example, in Stargardt that actually have a better prognosis. So a lot of information is available about this, genetic mutations today. So what is the take home? Diagnosis, phenotype is the key to interpret the genotype. Prognosis, of course, multifactorial, and clinicians have a very, very keen role to play. Thank you so much.
Thank you, Dr. Rajani. Unni's request was that the discussion should happen at the end for the next 3 talks. I'll now invite George Manayat from Aravind Eye Hospital, Coimbatore, excellent in retinal imaging, to speak to us on predicting treatment response in DME and other vascular retinopathies.
Thank you, Unni, and let's look at predicting treatment response in diabetic macular edema. I would be looking at non-invasive imaging biomarkers, mainly the OCT and OCT angiographic predictors of vision. So the OCT biomarkers, the first one would be a central subfield thickness. And this is a central 1 millimeter zone of the OCT map of the macula. And it has been already shown that increased baseline CST on OCT has decreased visual acuity as a predictor. But even the decrease of central subfield thickness from the baseline with anti-VEGF therapy is also shown in multiple studies, that it's at the baseline as well as a reduction is a response to anti-VEGF and predictive of good vision. But the problem is multiple major studies like Protocol A with focal laser for the macular edema, at most there is a modest correlation between vision and baseline CST. and even in the change in vision and change in CST is with focal laser has been modest. Even the eyes with thick maculas has good vision and vice versa. So there is a paradoxical visual acuity outcome. So OCT measurement of the central subfield thickness may not be a good surrogate for visual outcome in DME management. Even protocol T with anti-VEGF therapy showed that there is at best a moderate correlation between vision changes and changes in subfield thickness with anti-VEGF therapy. So is the thickness of the macula predict the visual outcome? No. CST is useful anatomical surrogate for diagnosing and monitoring DME, but it's not an accurate predictor of visual outcome. So then we have the OCT subtypes of DME like diffuse retinal thickening, cystoid edema, the serous macular detachment, and tractional DME. And few studies have shown that the large cystoid type of edema has worse vision than the other OCT subtypes. When we are talking about cystoid type of edema, it's not just the presence of cyst, the number of cysts, size, and their location. For example, large outer nuclear layer cyst more than 200 microns has negative impact on the retinal sensitivity. And most importantly, it is the residual tissue at the fovea, like this, as you can see, the bridging retinal process where the Mueller cells and the bipolar cells connect the outer retina to the inner retina, and the transmission of visual impulses that is most important in cystoid macular edema subtype of DME on OCT. So the bridging process is a positive predictor of vision outcome, and the serous macular detachment subtype where the external limiting membrane is disrupted in these cases, it has a favorable vision outcome if this is present at the baseline when we start the treatment of DME. And since there is an inflammatory theory with serous macular detachment and hyperreflective foci, DEX implant has been shown to be more effective than anti-VEGF therapy. So when we look at this subtype of DME and on OCT and the visual prediction, there is no consistent data that any morphological subtype has a significant prediction on visual outcomes in general. So coming to another predictor, that is hyperreflective foci, which are less than 30 microns. These are precursors of hard exudates at the fovea. These are lipoprotein extravasations because of the inflammatory process involved in the inner blood retinal barrier. There is activated microglia, and these multiple hyperreflective foci is associated with severe DME as well as poor vision with anti-VEGF therapy. And even in this setting, this biomarker, steroids have been shown to be much better in visual outcome compared to anti-VEGF therapy. So when you have multiple hyperreflective foci in the outer retina, there is an ELM disruption that is present along with in most of the cases. So another biomarker is hyperreflective foci in the choroid in DME, and this has been a poor prognostic marker because it's associated with severe forms of diabetic retinopathy like proliferative diabetic retinopathy. Again, a poor predictor in the management of diabetic macular edema. Coming to drill or the disorganization of the inner retinal layers, it is on OCT, the horizontal extent in microns of where the loss of boundaries of the inner retinal layers are lost. How to find a drill is track these inner retinal lines to the foveal center, and if there is loss of boundaries, this is how you find the drill within an OCT of DME. And the destruction of the bipolar amikran and horizontal cells which transmit the impulses again from the outer retina to the ganglion cell layer is disrupted in drill. And the centrally located drill, that is if it involves more than 50% of the central 1 millimeter zone, then a poor visual outcome can be predicted. And also the drill change. That is, if the extent of the drill changes by around 300 microns in the central 1 millimeter, if there is an increase in drill, you can expect a drop in vision over the next 8 months in such situations. So change in drill extent would be a robust predictive biomarker for visual outcome, more robust than the other changes on SD-OCT parameters. So for further therapeutic trial for treatment of DME, this would be a good marker rather than central subfield thickness alone as a biomarker. And this line or external limiting over the photoreceptor line, this where the Muller cells plexus with photoreceptors, and when there is a disruption of Ilm, fluid comes into the outer retina and subretinal space, and this disruption of the external limiting membrane is a good prognostic. It is associated with less vision outcome and a good prognostic marker to predict the outcome in DME. Also the ellipsoid zone, this layer of ellipsoid zone above the RPE, this is a macular photoreceptor inner outer segment junction. So the percentage disruption of ellipsoid zone helps the clinician more accurately to predict the visual outcome when you start the treatment with diabetic macular edema. So it is shown that ELM disruption happens before the ellipsoid zone disruption. So the grading is grade 0 with no disruption, and grade 1 only ELM, and then grade 2 along with EZ disruption. So this correlate well with the logMAR visual acuity outcomes. So coming to the choroidal biomarkers, we know that the DME is generally associated with thinner choroid, but if you have a DME with greater baseline choroidal thickness, then you expect better anatomical and functional response to anti-VEGF therapy, because the intact choriocapillaries in thick choroid is associated with less outer retinal ischemia. So that is about the choroidal biomarkers. And parallelism, these subfoveal photoreceptors are skeletonized and segmented into linear lines of segmented lines, and in DME there is a loss of parallelism here, and this loss of parallelism is correlated strongly with poor visual acuity outcome in DME. So a recent biomarker that is added to predict the diabetic macular edema outcome is the ICHRM, which is the presence of this material in the intraretinal cystic spaces, and this composite material takes around 6 to 7 months to form after the onset of DME. So ICHRM is a poor predictive marker in DME management, because it has been shown that the visual acuity in patients with ICHRM is poorer than eyes without ICHRM, and they require more number of intravitreal injections, whether it be anti-VEGF or steroid injection. So it's a poor biomarker in DME outcome. And last bit about the taut posterior hyaloid phase is associated with recalcitrant diabetic macular edema with anti-VEGF therapy and requires vitrectomy as a treatment option. And coming to touch upon OCT angiographic biomarkers, it is seen that the size of the FAZ enlargement, this happens first in the deep capillary plexus and then in the superficial capillary plexus. So if there is only FAZ enlargement in the deep capillary plexus, and then a good response to anti-VEGF therapy can be expected. And this FAZ size can be quantitatively measured, unlike dye-based angiographies, and a larger FAZ has been shown to correlate with the presence of drill on the OCT-B scan. And also the vessel density, capillary vessel density loss is also another sensitive marker for hypoperfusion, and it affects both superficial and deep plexus. And intercapillary spacing also is a more sensitive parameter for foveal hypoperfusion than FAZ size and vessel density. And this fractal dimensions, where it is the geometric arrangements of the capillaries at the fovea, is reduced in DME, as you can see on the right side, and the reduction in fractal dimension happens both in superficial and deep capillary plexus in DME. So to compare fluorescent angiography and Octa, we can advantage is that layer by layer we can study these parameters of FAZ size, vessel density, and intercapillary spacing, and this choice in pregnant and renal patients with DME. So to sum up, the negative biomarkers that we discussed, the increased central subfoveal thickness, the presence of drill, the large cyst in the outer nuclear layer, ELM and EZ disruption, hyperreflective foci in retina and choroid, and taut posterior hyaloid. So we expect a good visual outcome when there is a baseline serous macular detachment type of subtype, OCT subtypes, intact ellipsoid and Ilm zone, the bridging retinal processes, absence of hyperreflective foci. And also increased subfoveal choroidal thickness is also a good biomarker for outcome with diabetic macular edema. So OCT and OCT biomarkers not only help us to grade the severity of the disease, modify our treatment plan, and also help us to predict the visual outcome in DME in treatment. So thank you for your kind attention.
Thank you, George. That was a nice talk. We'll take all the last three talks or questions in the end. We have supposedly a free no session after that, so we can take talks. Next, I'd like to introduce Dr. Parveen Sen, who is a senior vitreoretinal consultant at Shankar Netralaya. Ma'am is a great academician, surgeon, and clinician. Over to you, ma'am.
Thank you, Uni. Thank you for the introduction as well as thank you for the invite. And I think the last topic is the predicting treatment response in exudative AMD and its variants. First, I would like to introduce how do we define a response. So how do you know that this case is responding or not responding? This is an article which has been published in 2015, but I think it's still quite relevant. So we need to look both at the morphological and functional biomarkers for defining the response to treatment, and the functional is best gauged with visual acuity, and improvement of visual acuity of anything more than 5 ETDRS letters is supposed to be a good response. 0 to 5 is something like a partial response, and no improvement is visual acuity is a poor response. And morphological, I would say that a reduction in the fluid compartment, or whether it is IRF, SRF, or the complete CRT of up to 75% is considered a good response. 25 to 75% is probably a partial response, and anything less than that you can say it's a poor response. Primary failures are gauged only at the end of 4 months, once you have given 3 loading injections at a monthly interval, and now you want to gauge whether the response is good, poor, or inadequate. This is the time to do it. Before you term recalcitrant CNV, make sure you've given 6 monthly injections, and then if the patient does not show a good response, you can label it recalcitrant CNV. So these are the terminologies which are used to really represent the response of therapy. In addition to the fluids, the subretinal fluid, intraretinal fluid, and the sub-RP fluid, there is also now another few manifestations of persistence of disease activity, which has now recently been published to 2021, and this is the CNV enlargement. So CNV enlargement was considered as one of the parameters to gauge the response of treatment even in the View 1 and View 2 studies, but now with the advent of Octa, which is non-invasive and it gives us very clear and fast pictures of the size of CNV, we can probably look at it more often. And in the subsequent slides, I will show you how we can use it to improve our treatment protocols. And any subretinal hemorrhage, which is new, is also considered one of the indications of persistent disease activity. So this persistent disease activity is seen in all sorts of cases, all response to all kinds of anti-VEGFs, even the longer acting and the best anti-VEGFs supposedly which are available, and all treatment protocols, whether you use it PRN or you use treat and extend, some proportion of cases will have persistent disease activity. So what are the predictors of this kind of inadequate response? The first to begin with is not just that I'm beginning here, but actually most of the studies have found that the visual acuity is actually the most important one. Age in some studies has been considered. With increasing age of the patient, especially more than 80, 85 years of age, they usually have a poor response to anti-VEGF as compared to something 60 or 70-year-old. Shorter the duration of disease, better the response, and significant baseline predictor in almost across all studies or trials has been that good baseline visual acuity is associated with good response. So this is something commonly we also see in our patients. OCT based parameter, the first, most important, the easiest to access is probably the central retinal thickness, or CST, central subfield thickness. Just I would leave it at that this may not be the best parameter, but it is the easiest to gauge. So anything thicker than 425 and thinner than 325 probably also could mean a poor response to treatment. And then, though this is a real repetition and all of us are really very familiar with it, but I cannot skip it because this is the most important parameter. the subretinal fluid, the intraretinal fluid, and the pigment epithelial detachment. Out of this, the intraretinal fluid is most important as a predictor of visual acuity. All the trials have shown that whenever you have IRC formation, the visual acuity really drops and you need to treat it very early. Pigment epithelial detachment almost present in all cases of wet AMD, and interestingly, whenever you have a pigment epithelial detachment early on at the baseline, the visual acuity of the patient may be very good, so it does not correlate with the visual acuity. But in the end, if you see the over a long term, patients who have had a pigment epithelial detachment to begin with tend to do worse in response to therapy, probably because of the sub-RPE seat of the fibrovascular prolif, which is fibrovascular tissue which is there. The access to the treatment is less. CNV size, the smaller CNVs are supposed to respond better because the load is much lesser, and any increase in the baseline CNV size is now been correlated in studies that the improvement in visual acuity can be reduced by as much as 5 letters. Type of CNV. So you need to qualify, not every lesion and you just start giving anti-VEGFs, but if you try to look into it, if it's a type 1 CNV, great visual acuity at presentation, but finally may not do so well. Type 2 CNV will respond very quickly, but may form disciform scars. Type 3 CNV, good response, but may end up in a geographic atrophy, and this is an example from one of the publications, and they have mentioned that the occult form of CNV, or the type 1 CNV as we now know it, or is the one which responds poorly. Type 3, very good response initially, but they are the ones which are largely known with formation of macular atrophy, and also they are the ones which are known with diffuse sclerosis of choriocapillaris or a thin choroid, and because of this actually the term of CNV was changed to MNV to include these RAP lesions because their origin is not choroidal anymore, their origin may be retinal. So now we call them as MNV and not a CNV. This is one of my patients. You can see July 2021, just a little elevation of the RPs, all that the patient had, and then suddenly came with a sudden drop in vision. These MNVs are known to progress really fast, and the large pigment epithelial detachment, which is this is typical. The on an Octa, you can easily pick up the formation of a RAP lesion here, temporal to the fovea, and on the flow map you can see that there is a communication with the retinal flow as well as the choroidal flow. This is the other eye of the patient, and you know when I say that macular atrophy is the one thing which happens very quickly in the RAP lesion, and the patient does not gain good visual acuity even if the response to therapy is adequate. Another thing, subretinal fibrosis, we know all the clinical studies, all the trials keep this as an exclusion criteria. Why do they keep it as an exclusion criteria? Because once you see subretinal fibrosis, even if your fluid goes, even if your IRF goes, even if the VEGF is working, visual acuity is not going to improve. So it is going to hamper all your results. So this is seen in almost 25% of the patients. One of my patients' example here, you can see, on clinical examination itself, you can see a yellowish material which is formed subretinally. And if you see the OCT here in lower picture gives you the presence of this fluid which is here. The Octa gives you a good type 1 CNV which is present. Usually you have most of this fibrosis with type 2 CNV, but with sometimes type 1 MNVs can also give rise to this kind of a fibrosis. The response to treatment is there, but the patient never improved beyond 6/24. Similar thing can happen with subretinal hemorrhage, though less has been spoken about this, but whenever you leave this subretinal hemorrhage untreated, it can actually consolidate and form large scars, and which is what we see most commonly in PCV eyes. And subretinal hyperreflective material or SHREM, most commonly seen in a type 2 or a type 3 MNV. And here again, now we know that there are vascular and avascular SHREM. Vascular SHREM means there is a part of MNV which has ruptured through the RP and now sitting above the RP as well. And this component which gives the SHREM or the hyperreflective material a vascularity is going to be a poor visual outcome, because they are not only less responsive, but they are going to form large disciform scars. Vis-a-vis the avascular SHREM, which is actually going to melt away sometimes with anti-VEGF therapy. I think RP atrophy, ma'am has covered very nicely, but associated with the choroidal neovascular membrane, if you see, you have to think how much injections can you give to the patient, because the injections can supposedly increase the macular atrophy as well. These are the few risk factors we saw in association other than CNV which can cause macular atrophy. So the number of injections have to be limited in these cases. So various types have been described of CNV has been described on Octa, and the presence of activity is increased peripheral branching, presence of inner loops, and there's a hyperfluorescence halo around it. So here we can now actually measure the area of the neovascularization, the length and the caliber. Most important features, I would suggest, like to spend a little time on this, that there's a prominent central vessel trunk which is present. That may not regress because secondary to anti-VEGF, because these prominent trunks get laid up with pericytes and the response to anti-VEGF becomes lesser. It is the peripheral fine vessels which are going to really regress, and that is what gives the dead tree trunk appearance. This is the example of the central trunk which is present and which is the one which is not going to respond to anti-VEGF therapy. A very nice example, this is one of my patients. You can see how Octa has helped me to the diagnosis. Some of the fluid persisted, but I did not switch treatment or anything. I continued what I was doing earlier because Octa showed me very well that the CNV size is definitely reducing, and it is only a matter of time when the fluid will go away. Quantitative assessment, new algorithms like Vista can allow us to do a quantitative assessment, and you can see the flow. And then this choriocapillaris flow deficit, though it is more important in cases of a dry AMD, even neovascularization can have increased areas of CCFD, and if present, they definitely show reduced vascular supply. Autofluorescence has not really been shown to be very useful biomarker, and few genetic types have been shown to be associated with poor response vis-a-vis the others, but we are not at a stage where we can do genetic analysis for our AMD patients. So I have a little time, just 2 slides or 3 slides, which I would like to show how to gauge the treatment in PCV. We know now that OCT we are using to look at the diagnosis of PCV, but we are also seeing the response to treatment. So this is a slide which I have taken from a very recent article by Tan et al. It is from Gemik Chong's group. So this is normally how we see that there are nodular hyperfluorescence on ICG, where we see that these are the active polypoidal lesions. But they have tried to see what are the features of response in polypoidal lesions on OCT, and we really need an ICG to say that it is active leaking polypoidal lesion or not. So this is something you can see that the height of PED, you can see the fluid, these are the important features, and there is a hyperfluorescent ring on the undersurface. So all this stays as such, and this is a non-responder. Below is the picture which shows that the fluid has gone away here and there is no fluid post-treatment. Then this hypospace below the PED has become hyper now. So hyper-echogenicity below the pigment epithelial detachment shows that the response is there, and the ring-like hypofluorescence echogenic area is also not visible anymore. So increase in the echogenicity of the sub-RP space is actually a good sign of looking at response to treatment. So these are the few biomarkers in PCV which can tell you whether your polypoidal lesion is responding or not. For the BNN is responding or not, we can still look at the SRF and the IRF. And of course, it's not far away that we will not have to really do all this, because deep learning and artificial intelligence, they are forming algorithms to look at the response to treatment. To summarize, there are several morphological and demographic and OCT and OCTA biomarkers. Smaller size SRF, RAP, they may respond to anti-VEGF therapy very quickly, but larger CNVs, older age, PED, IRC, and vitreomacular traction also can be a poor biomarker of disease. Thank you.
Thank you, ma'am, for that elaborate talk on the predictive values. Do you have any questions for the last 3 talks, please? I think those were excellent talks on this session. We'll conclude the session now. Thank you for joining us, and have a nice conference rest of it. Thank you.